Hello, everyone, and welcome to my capstone project on massive transfusion protocol here at White Plains Hospital. My name is Aimee Capstone. I'm an MSN education student at Aspen University, and this is my capstone. This PowerPoint is aimed for new but experienced providers and nurses at White Plains Hospital. We have an internal protocol created here by a laboratory staff. There are actually two that go into one MTP. This is an overview of a little bit of both of them, but mostly a focus on the bedside aspect. There are two: massive transfusion protocol for laboratory and the massive transfusion guidelines for bedside. The objectives of my PowerPoint. By the end of this presentation, the student should be able to understand and discuss the following: how to activate the massive transfusion protocol, who activates it, when and why, how to properly report SBAR style on an actively hemorrhaging patient for a doctor to come to the bedside, what our hospital ratio for blood products is within WPH, and how we deactivate this protocol, which is also very important. Learning outcomes. Every learner will be able to demonstrate knowledge of MTP specific to our MTP at WPH, what the RN responsibilities are versus what the MD responsibilities are during a massive transfusion, what MTP is and why it is important for all patient safety, and how to properly start and stop the entire process. So a little bit of background information. For those of you who know me, I've been an ER nurse at White Plains Hospital for over 3 years. I was an L&D nurse for about 3 years as well, so I have been at the hospital for a while. I find this really important because though we are not a trauma center, we do see sicker and sicker patients every single day. As someone who worked on L&D and in the ED, we see sick patients on both sides. And it is in my opinion, and also in the literature, that early identification of these patients that are at risk for needing a massive transfusion, which we will go into deeper, which ones are considered a massive transfusion. The faster we move and faster we trigger the protocol, the faster they get their blood. This, as we will discuss later, a lot of times there's breakdown in communication between us at the bedside and the laboratory on what needs to be done next, or what should be done first, or, kind of a back and forth. When we trigger MTP, we cut down on time, we save lives. Cut and dry. Cryo cooler, which we will discuss further as well, basically makes it so as we pick up the first set of blood for our patients, laboratory, without being told, is already working on the second packet of blood for another cryo cooler to bring to the bedside. It cuts down on both communication errors and it makes it faster. My pre-survey. I created a 10-question pre-survey. I did about 71 people between labor and delivery in the emergency room, mostly nurses, doctors, physician assistants, a few nurse practitioners here and there. I did have to go through and remove a few because a couple of people, wrote on it, they were scrub techs or they were nursing techs, and this is aimed towards the providers, the nurses, and the doctors. So I had to remove a few. So I think in the end, I actually did a survey of 64. My kind of breakdown was that 97% of people knew that we had a protocol, but were really not sure of the rest. 60% of people realized that we do receive our blood and our packets in the cryo cooler, but were unsure of the actual ratios. And 80% of people understood how to trigger the protocol, but maybe not exactly who was involved. So our hospital's massive transfusion protocol is a hospital-based written protocol for massive transfusions written by our amazing laboratory staff, Beth Berteline. It is an explanation of how the interdisciplinary team can streamline communication between us, the ER triage-based areas, and labor and delivery with the laboratory staff to help quickly identify hemorrhaging patients early on and trigger it so that the blood bank can start working on the blood to cut down on time between the communication and the blood getting to the bedside, if that makes sense. It is a way to alert the blood bank that we are going to be needing a lot of blood quickly so that they can not only create the blood that's being sent immediately, but immediately start working on the next packet. It is a protocol that basically helps delineate the responsibilities of each area, nursing, doctors, and lab, and helps cut down on critical time. Because as we know, time is the biggest factor when patients are hemorrhaging. So who is a candidate for the massive transfusion protocol? There are actually two different ways to delineate if a patient is a candidate. One is a patient that is identified to need 4 units of packed red blood cells in less than 4 hours, or 10 units of PRBCs in 24 hours, unstable vital signs with a suspected bleed, or uncontrolled bleeding with a known source. Or any patient with an initial blood loss of at least 40% of their blood volume, whom it may be judged to need at least 6 units of blood replacement immediately, not over 4 hours, but this time immediately. Or any patient with an ongoing or continuous hemorrhage of at least 250 milliliters or more. Or any patient with a history of hemorrhaging with changes in their vital signs, hypotensive, tachycardic, or a positive FAST scan, or a pH of less than 7.25. And lastly, any patient with clinical judgment with an identified source of blood. So there's a lot of different ways to qualify a patient for the MTP protocol. And as I tell people a lot in the ED, if a patient is bleeding and their vital signs are changing, there's obviously coming from somewhere. So bring it up to the doctor. They can, with their clinical judgment, deem a patient necessary for MTP. And really interestingly, where it has the continually hemorrhage of at least 250 milliliters an hour, I know recently labor and delivery has gotten into doing QBL for every delivery and in the OR. So if there is post-delivery and the patient is hemorrhaging, please make sure to do the QBL, because you can actually bring up to the doctor that the patient has lost 250 cc's this past hour and is on their way to losing 250 cc's the second hour. They should be triggering massive transfusion protocol. So this PowerPoint is aimed towards people that have experience, so we all know what SBAR is. Never be afraid to approach a provider when you get a new patient that you think is actively bleeding and their vital signs. You look up at the monitor and the vital signs are just not what you would expect. So I'm just going to do a quick breakdown of what a good SBAR could be, being like, I need you to the bedside now. So my example is situation: 79-year-old male brought in by ambulance for an unknown source of bleeding and red blood found in the bed. The background: the patient lives at home and has a history of being on Eliquis for AFib assessment. His vital signs are unstable. Elevated heart rate of 128, notably hypotensive at 70/40, and he is still mentating at this time, which is important to add. I highly recommend that you go to see him immediately. I believe he might need blood, and if we activate now, we can get 2 units of packed red blood cells to the bedside quickly as possible, even though we don't have a type and screen yet. I believe it is necessary and the fastest way to get both the doctor to the bedside and get the uncrossed blood to the bedside quickly. So this is a scenario where a patient was brought in by ambulance. He was thrown into bed 3 quickly, and we're moving now. So what are considered unstable vital signs? Funny enough, the protocol does not actually discuss clearly defining the vital signs, but utilizing our critical thinking, we can determine what unstable vital signs are, and kind of what I did was I went into our RRT protocol and copy and pasted what they consider unstable. Heart rate of greater than 150 or less than 40, systolic blood pressure less than 90 or a MAP less than 65, and lastly, an unknown or known source of uncontrolled bleeding. Our written massive transfusion protocol does have an algorithm in it that is tailored toward the OR, but it is stated within the protocol that it can be modified to be used anywhere. So once a patient is identified as a massive transfusion candidate, then the steps are identical. You call the blood bank, you state you need the massive transfusion, and you state the patient's name, medical record number, location, and be very specific if they are moving. Status of blood sampling, whether or not they've had a type 1 screen during this stay, or if they've ever been a patient here before. And what is our plan? Is our plan to give 2 uncrossed now? Is our plan to wait for the cross-match blood? Or is our plan to start with 2 RBCs now, 2 FFP now, and then go for the protocol? Because it can be changed. Then on top of that, we have to request the blood. We have to designate a runner who's going to go to and from blood bank who has all the information on the patient. We need to then send a type and screen as quickly as possible. And if the blood is going to be uncrossed, it needs to be the emergency transfusion request, which is a small form done immediately that's brought to the blood bank. Also, if possible, the doctors are supposed to go into the computer and put the request in for the massive transfusion. Obviously, if the patient is this unstable and the doctor cannot leave the bedside, someone else will have to do it, or there needs to be a second provider helping. So we've identified our patient as needing MTP. We have a source of bleeding. Patient is exsanguinating. The doctor, the MD provider, or the PA or anesthesia can say, okay, activate MTP. So what is then done is that MTP is activated by a member calling the blood bank saying, hey, we need MTP. At that point, we also discuss whether there is a type 1 screen available for this patient with all the information we discussed earlier. The blood bank then will tell us what they need next, and we then talk about whether the patient needs uncrossed now or they can wait for the cross matching. Okay? There really should be no delay at all. I know it sounds difficult, but once the order is placed in Epic, or the blood bank is called saying, hey, we can't get to the order yet, they're aware. They'll start getting everything ready as long as you give them the patient name, the patient medical number, location, where they're moving to, if they're moving or not moving, what products are needed first, even though our first, our delineation is 4 units of RBCs and 2 units of FFP. We can request 2 uncrossed first, which is fine. Is there a type and screen being sent now? If it is, should it be brought down by hand? Or what is the plan for blood delivery? Who's going to be the runner, basically? The blood bank, that's very helpful for them to know. So what I found by surveying all of these nurses and doctors is that there's a little bit of a confusion on what's the doctor's responsibility versus what the nurse's responsibility is. So the doctor's responsibility is to come and assess their patient when the nurse says, hey, I have a bad feeling about this, or hey, I believe the patient is bleeding, their vital signs are unstable, I need you at the bedside now. So the doctor's responsibility is to come to the bedside, assess their patient, and assess the need for MTP triggering, okay? They are the ones that then say, okay, I need MTP to be triggered. The nurse or the charge nurse can then activate saying, hey, our doctor says we need MTP. They call the blood bank on 1258. I don't know if there's a type 1 screen. Okay, so then it becomes on to the RNs to recognize the stable vital signs, call the MD to the bedside, call the bedside, verify type 1 screen status, and ensure the patient has 2 lines. When a patient is bleeding, what is number 1 that we need to do? 2 lines. The protocol also goes into depth. Now, what should we do during the actual transfusion? Nurses need to monitor the patients for hypothermia. They need to ensure that the blood is given right away once it comes to the bedside. We need to ensure that they do not deviate from our, blood setup. Do you still need a second nurse to verify? Absolutely. An emergency situation, can you verify with a doctor? Yes, but you still need a second nurse to come in and verify if you're giving uncrossed blood. Okay? Also, other thing that everyone needs to remember is that FFP, platelets, cryo can take up to 30 minutes to thaw. So something that should be on the back of everyone's mind is what's coming next. The blood bank, the whole reason for this MTP is so that the blood bank is already working on that. But if you're thinking to the next step, call blood bank and make sure what's being created, okay? Or what's being sent next. As we've discussed in the beginning of the presentation, there are actually 2 protocols. There's the one for us at the bedside, which I've been kind of harping throughout the entire presentation. And there's a little second protocol that's created also by Beth Berteline that discusses how they actually get everything ready in blood bank, which I feel we should go over quickly just so everyone knows. This is kind of what laboratory is responsible for. So laboratory is responsible for identifying whether this patient has a known type and screen. So if a patient has a known type and screen and they're eligible, we issue 2 red blood cells that are crossed but not matched with this patient, and then they continue to go forward. If a patient has no valid type and screen and it's never been done before, they need the 2 type and screens, which we know at the bedside, and then they need to do the emergency release of 2 uncrossed type O, and this is where there's a bit of a change, okay? If a patient is an adult female under the age of 50, they're going to get O negative no matter what. When there's an adult female above the age of 50 or any adult male, they will get O positive. And then if it's any pediatric patient, they will also get O negative. I just think it's something that's interesting. So when you have an adult male that's hemorrhaging, which by the way is also 70% of our hemorrhages tend to be male, why you're giving O positive. It is because they do not have the ability to childbear, which is really interesting to me. Okay, so now let's get to the nitty gritty of when you've activated MTP. What are you going to get in your packets of cryocoolers? All right, so our first massive transfusion packet is 4 units of red blood cells and 2 of plasma. Okay, when you get that packet and you bring it to the bedside, the laboratory is already working on packet number 2. Okay, packet number 2 is 4 units of red blood cells, 2 of plasma, and 1 of platelet. Why is platelets not in the first packet? Because it takes 30 minutes to thaw. So it's very interesting. Our third MTP packet, which it will be created the second we pick up our second MTP packet. It will be created by the laboratory staff as we are hanging the second packet. 4 units of RBCs, 2 of plasma, 2 of platelet. Okay? So at this point, your patient is saying, doing a little better. Okay? What should we do next? Should we call the laboratory and tell them to cancel that 4th packet? No. You need a doctor's order to do that. Okay? But say, the patient's doing well. The doctor says, I don't really need the red blood cells anymore. I think we should just go ahead with cryo. So what the doctor can do is call the blood bank and order it as an adjunct, or he can cancel MTP and then order the cryo after. Okay, so we've activated MTP and we have everything at the bedside. What can we do to give the blood? We can hang the blood to gravity, or we can use the rapid transfusion if the patient is losing blood at a rapid rate. Okay, we still follow our nurse-done protocol of 2 units giving blood, 2 nurses at bedside reviewing the unit to give blood. Patients have at least 2 lines and should be having their vital signs taken every 15 minutes minimum. If the patient is actively bleeding, they should be considered giving any kind of pharmacological therapy at this point. We should discuss TXA, which is a big one down in the ED, quick clot if you can identify where it is, or a patient should be stable enough to go to CT to find out where the bleed actually is coming from. We should also always work on getting a type and screen. This helps not only us to help make sure that the patient does not have any long-term effects from being given blood that isn't their crossed and matched for them. Antibody problems, there's a whole list of problems. That is actually going to be for my next project for the end of my capstone, is looking at the side effects of massive transfusions and how the patients do afterwards. So it's very interesting to me. And one of the big findings is that type and screens actually help us cut down on all those problems. So something we should work on. Labor and delivery, you guys have activated your MTP. You guys have your own kind of safe motherhood obstetric hemorrhage list, which we are going to go over as well. You guys have a rapid transfuser. It slightly differs from ours in the ED. It also is a warmer. And the one thing that I ask is that you guys always ensure that the doctor set up, because it is almost always anesthesia that sets up in the OR, saline as the primary line, not LR. So that's always a big one. Make sure that you have a nurse double check on that as well. And oftentimes it is already set up. So like this one I found in OR2, took it down after I found it because it had been there probably 24 hours. So labor and delivery is very specialized in the sense that when they have an OB hemorrhage and it is noted that a patient is bleeding, they actually follow an obstetrics checklist. They rely on pharmacological therapy, similar to us in the ED, but they have a very tailored response. When a patient is actively bleeding, they ensure that the patient has an 18 gauge, they increase fluids, they immediately insert an indwelling catheter because one of the side effects of a full bladder is actually it displaces the uterus, causing bleeding. They confirm, and they often have, and they do very well with this for C-sections or for high risk for bleeding deliveries because they do a pre-survey of the patients, units already at the bedside. They have 2 units at the bedside in the cryocooler waiting. So they're a little bit more prepared in the sense that for bleeding because every patient upon admission gets screened for this. And when they trigger the protocol, they have 2 units at the bedside during delivery or any active stage or during the C-section. So this is something really great, and Jane does a really amazing job of making sure every new nurse on labor and delivery goes through the high-risk OB course with her, and she goes through all the medications from Cytotec to Hemabate to Methergin to using the Jada and to using, you guys don't really use the balloon anymore, but, she does a really great job of all the thrombotics. So this is actually the addition to the paperwork. It's actually done by Blood Bank. It is the Epic kind of charting on a piece of paper for them so they can keep track of what's been kind of handed to the staff for this patient who's triggered massive transfusion. It's the patient's name, MRN, date of birth, whether they're male or female. We've already kind of gone over why they need to know that, where the patient is, and if they're moving, was the order ever put in Epic? Because sometimes it is forgotten. We discussed that. The activation was done by who, what date and time, and who is actually preparing everything. The emergency release part is we discussed that. We give them an emergency release form, and they give us the 2 uncrossed packed red blood cells, and then they start working on the next part. As you see, they create the packets. Kind of when did they get the packet ready? At what time is everything in the packet? Packet 2. What time do they get it ready? At what time? And so on. It's a really good way just to track what's been created and what's taken from the blood bank. So I just wanted to add this little piece because a lot of people in the pre-survey did not know that our protocol was for red blood cells to 2 plasma to 0 platelets in the first round. Because a lot of people actually did know this, that the ratio should be closer to whole blood, 1-1-1. I really thought this was interesting because it also just goes to show how many of us have this trauma-based mind. Okay, patient's losing whole blood, we should replace whole blood. Because it's this idea that PRBCs don't have the clotting factors, and if the patient is actively bleeding and we can't stop it, we should replace it with whole blood. I just really wanted to add this in here because despite our protocol having its, downfalls and everything. They did an amazing job with it. And they write in here that they are aware that you should be giving platelets and plasma with it, but in our end, it's very difficult because those need to be frozen. So, but this idea that, okay, as we're replacing the blood, we need to replace everything. And it is actually discussed in the protocol as well, which is really wonderful. So how do we discontinue or stop our MTP? The only person who can stop an MTP from going is an MD who comes to the bedside, assesses their patient, and deems them stable enough to no longer have the next round of blood. So the second it is done, the nurse or the charge nurse or the doctor, if they're so inclined, calls the laboratory, or blood bank, excuse me, I keep saying laboratory, but it's because it's lab staff that works in the blood bank, and says, okay, this patient is stable enough that we're going to cancel MTP now, and we will return to you your filled out tracking form and all of the blood forms. Often these MTPs were moving so quickly, we often lose the blood forms. They need to be kept together in the patient's chart and returned to blood bank, especially when a patient is giving uncrossed blood. All right? Thank you so much to everyone who sat through my 23 slides of jabbering. I know a lot of you know me and know that I get really interested in critical care ideas, and hemorrhage is kind of where I thrive. So I was really happy to create this project. I know I harped and followed people around to do my pre-survey. I'm unfortunately going to do that again with a post-survey over the next 3 days. If you all don't mind, I am really interested in knowing what you guys thought of my presentation. Please feel free to email or call me anytime. My number is now here, right there at the bottom. My emails are there as well, my work email and my personal email. I would love to hear from everyone who has anything to say about this. My capstone is not finished for another actually 6 weeks. I'm going to be going through and kind of still presenting and doing things, but this was the best way to kind of send it to everyone at once. I really hope you guys learned a little bit. I know our protocol is a little bit confusing because there's a lot of moving parts, but I know as we all learn it and as it rolls out more and more, we're all going to do a great job with giving blood and with communication and understanding kind of where we are as nurses. We're the people who facilitate this. We're the people who call the doctors to the bedside when we have a bad feeling, or the ones who are with the patient when we identify that the bleeding is getting worse. So thank you guys so much for just giving me a little of your time.